Awesome. So good morning and good evening all. Namaste and a warm welcome to the monthly webinar series hosted by Gupta Klinsky India Institute at Johns Hopkins, or as we love to call it, GKII. GKII brings together the Johns Hopkins community, including faculty, staff, students, and alumni, and a diverse range of Indian partners to improve society in India and beyond through research, education, policy, and practice. Through the webinar series, we also aim to have an engaging and a meaningful dialogue that pave the way for further enriching discourses and advancements in evidence-based and sustainable solutions to the healthcare challenges of India. The topic for this month's webinar, as you all are already aware, is post-pandemic lessons from India's perspective. And our guest speaker is Ms. Priyam Gandhi-Mody. Hi, Priyam, welcome.
Hi, lovely to be here. Thank you.
So it's a pleasure definitely to have you over here. Priyam is an author and a political strategist. She has written 3 political non-fiction books, including Trading Power, No Holds Barred, and the latest, A Nation to Protect, which chronicles India's pandemic handling from a top-down perspective. Priyam has also written opinion pieces for India, for the Indian and international media, beg your pardon, most recently for the Telegraph, the Epoch Times, the Economic Times, and the Indian Express. And she has very confidently shared her opinions through media appearances, including CNN News 18, One America News, Dubai One News, and several other media outlets. Priyam is also a qualified policy analyst and has pursued her master's degree from the Florida State University. She is an alumna of University of Delaware and has worked in the political ecosystem in Tallahassee before moving to Mumbai, where she currently resides. As you all may be aware that this webinar is in a Q&A format, where we will ask Priyam to share her thoughts and research related to questions on India's pandemic management and lessons learned. Regarding the format, we will spend around the next 40 minutes on this Q&A series and leave the 5 to 10 minutes at the end to respond to audience questions as well. So please do post your questions on the Q&A chat box that we have. And with this, I would like to introduce Shri, Brian, and Kunchok, GKII senior faculty members and my co-hosts for the session. Dr. Sridevi Sarma is an associate professor in the Department of Biomedical Engineering and Vice Dean for Graduate Education at the Whiting School of Engineering. Hello, Shri. Dr. Brian Wall is an assistant scientist at the Johns Hopkins School of Public Health. Hi, Brian. And Dr. Kunchok Dorji is an assistant professor of medicine at the Johns Hopkins School of Medicine. Hello, Kunchok. And well, before moving ahead, welcome again, Priyam. And before I hand it over to my esteemed faculty members for further questions, would you like to share a very brief about your journey as a writer while penning your recent book? I mean, just within a minute, if you're able to share the top 3 takeaways, 2 to 3 takeaways during this journey of yours. So over to you.
Right. Thank you. Thank you, Priyanka, for the very kind introduction. So when I started the book, we were sort of just getting over the Delta wave in India. And those were pretty challenging times. And that's when, the people I was talking to within the government, outside the system, there was a lot being done to overcome the challenges that a pandemic brings. And not all of that we were able to see in mainstream media. And I wanted to be able to cover all of it from a top-down perspective, and which is why I wrote this book.
Awesome. Thanks, Priyam. Mm-hmm. And I would request Kunchok, if you could take the lead and ask Priyam your questions. You're on mute.
Thanks. I first wanted to start really by saying that how India handled the pandemic, managed it, has been laudatory and inspiring. But there are always things, and one of the things that came up is from experts from medical fraternity and also from the global publications, there have been underreporting of cases. Some reports suggest 1 in 25 or so cases were reported. So my question is, what could we have done to make things better? How differently things could have been done? How disease surveillance mechanisms, better mechanisms could have been put in place?
Right. Thank you, Dr. Dorji, for this question. And, it's so relevant today as we look back and sort of look at the pandemic years, not just in India, but in all countries. So we always see that when there is a new virus, it takes time, a few weeks at the bare minimum, if not more, for us to really begin to understand the characteristics of the new virus and its implications on like its clinical implications on the population. So by the time we understand that, it's about 3-4 weeks, even more sometimes, and then the scientific community takes over to make the testing kits that detect the infection in the person. So all of this is time consuming. So my opinion is that not just in India, everywhere in the world, testing, there was underreporting of cases because testing was low at the beginning. We just simply did not have enough testing kits or that technology to upgrade the manufacturing of those PCR or rapid antigen kits on, at the pace that we needed to, at the pace that the cases were spreading. So definitely, yes. When I feel that the solution is to have a more sort of like agile scientific community that you can activate as soon as you have more information on the characteristic of the new virus, then take it from there.
Sure, thanks.
Thanks, Priyam.
Mm-hmm.
Brian, over to you. What are your questions for Priyam?
Sure. Well, first of all, hi, Priyam, and thank you for being with us today here at GKII. I also want to just take a brief moment to reflect on the importance of documenting the past 3 years and documenting the policies and the programs that have been implemented in response to the pandemic. There are still many lessons that we take from, for example, the 1918 flu. And as an epidemiologist, I'm sure the documentation of the pandemic and the epidemic in India is going to be critically important in years to come. And so I wanted to ask you that globally, vaccine hesitancy has been a burning issue, both for COVID-19 vaccines as well as for non-COVID-19 vaccines. And so I was wondering, in the context of COVID-19 in India, if you could comment on vaccine hesitancy around COVID-19 vaccines and what steps were taken, including from a policy perspective, to minimize vaccine hesitancy, and what was your observation of how these policies and programs were implemented?
Right. So in India, we didn't see the mass anti-vaccine protests that we saw in many other parts of the world. And a lot of that can be attributed to quick policy decision making at the center and state levels, even at local levels, by the government of India. So, for example, as you guys already know, we used two vaccines majorly. We have other vaccines, but we used mostly two vaccines to inoculate our population. One was a completely developed and made in India vaccine, which is Covaxin, made by Bharat Biotech. And the other one is the Serum Institute of India vaccine, which has the tech from the University of Oxford. But that vaccine is also completely made in India by the Serum Institute of India. So these were not So we had to build confidence in the population for the vaccines which are made in India, which the other parts of the world had not been using. So from a policy perspective, we didn't mandate the vaccine. We had people, so it was sort of like a trust building exercise from word of mouth that since that the government sort of, and this is right from the beginning of the pandemic, the government has been hand holding people through various, be it the lockdown or be it the unopened, the opening back of the economy. I think that right from the beginning, the kind of like trust building that the government did through the pandemic, that sort of worked even when it came to, building people's trust in the vaccines. Also, we had the Prime Minister take the vaccine right at the very beginning in full media glare. And I think that added to the authenticity of the vaccine and the trust in it as well. Also, if we saw that there were any rumors, which always happen at village or hamlet or tier 3 city levels, the government was very, very quick to produce real facts to counter those rumors. The government also used a network of religious preachers and community strongmen to sort of penetrate into communities about why these vaccines are important and essential, while also not really going overboard and mandating it or like blocking people who from public places who don't have vaccines. So there was no sort of like increased pressure, but also a simultaneous sort of trust building exercise going on. Does that make sense?
It does. Thanks, Priyam. I do have a follow-up question on that. Well, in terms of communicating with, say, with people residing in really territorially difficult regions, Ladakh, your J&K, Himachal, especially also the Seven Sisters, Northeast region, that area, where technically, primarily the intake of vaccines is not as high in general, if you see the annual, percentage uptake of vaccine. Also, given the situations related to COVID because of, lack of transportation, communications, etc., and then sort of being able to navigate that space of requesting people to come outside and take vaccines. So how any experiences, life experiences that you're able to share from the ground, from these specially cut off regions, for lack of a better word, how was that? How did that actually come into reality?
So the vaccination drive has been absolutely incredible in India. And I mean, the people to credit are the on-ground ASHA workers that we have. There's no doubt about that. But right in the beginning, the government sort of anticipated that it's going to be really the logistics of transporting these many vaccines to these kind of, spread out areas, in India is going to be very challenging. So which is why, the vaccines which had to be stored at, really, below freezing temperatures. So those kinds of logistics would have become very, very difficult for India to handle. So it was essential that we get vaccines that are easier to handle and transport and store. We don't have freezers in every pharmacy at every block. We simply just don't have that in India. So we cannot, so we had to create an infrastructure to handle the vaccines that we were going to give out. So that was very important. We had, even in the most difficult terrains, we've seen the healthcare workers sort of carry those vaccines in backpacks and cross over to really, really small communities, so that people get the jabs. And, that the uptake has been great too in those communities, thanks to how well, Indians take to technology and how well they took to the CoWIN app to make the appointments. And those that were left out of that system, who still didn't use an app or didn't have a phone or access to a cell phone with internet on it, we had the door-to-door campaign as well. So I think all of this sort of combined, really helped, especially in like the areas which are difficult, the difficult terrains.
Priyanka, if I may
Yes,
add
please.
that I think vaccine hesitancy is a critical issue, not just in India and globally. So from personal experience also, one thing that I think worked in India is the trust. I think you commented on that, the trust between people and the health system. I think that was crucial. People believed in the health system. Right? And that trust also came from community engagement, right? You mentioned about the ASHA workers and people on the ground. They were engaged in it. So I think those are some crucial aspects that need to be highlighted. Once you lose that trust, then all other negative determinants of uptake may start to kick in. And so just wanted to highlight these things that you mentioned.
Yeah, and just adding to that, Dr. Dorji, in India, we've seen the universal vaccination program going on for a long time, which is door to door. We've seen the polio drops given out to the kids, which is also door to door and handled by like the municipal corporations. And we still have those health workers coming in, they have a little bag, they remove like the drops, the vials, and nobody checks. There's just simply that trust. They bring their kids out, they'll open their mouth and they'll put those 2 drops in. There's that much trust, that they're safe and they're not going to use anything questionable on your kids. So that is very important, and it has been built over decades.
Right.
Also, given with the population that we have and majorly residing in non-urban areas, I think that's a great one of the key takeaways from this exercise. Definitely. Thanks, Kunjal. Shri, over to you.
Yeah, I mean, that's a good segue into what I was thinking about with respect to urban and tribal populations, hard to reach areas. I mean, you clearly make a great case in the book and now about how the Indian government, Prime Minister Modi, built trust, made these critical decisions to effectively, efficiently respond to COVID, vaccine adoption, distribution, great success story. But you also talk about lessons learned. And so I want to ask you about, key lessons learned. Like, what would be, say, your top 3 key lessons learned from India's COVID management experiences to ensure better outreach? So thinking about the last mile healthcare delivery.
Right. So the first key lesson, of course, is strengthening the primary infrastructure, the primary healthcare infrastructure. So we saw, especially during COVID, that at many places in the country, we were not able to stop the cases from progressing to moderate and severe in the village and the in the really regional areas. Those people who had whose disease progressed to moderate and severe, they had to move to the urban centers, and many times because they've not been able to get that treatment when they had the mild disease. So I think strengthening that primary healthcare last mile infrastructure is absolutely critical. The other important lesson is sort of covering more vulnerable groups into the healthcare, the universal health insurance program. So the government of India has started to roll it out, but the coverage is still not enough for people. And people who are already sort of poor or even lower middle class, having to have an extended hospital stay and these kinds of healthcare expenses, it just simply doesn't work. So that's another very important lesson learned, that we need to achieve scale in terms of healthcare insurance coverage that the government is giving out. The third is, of course, strengthening intelligence systems at even local levels. So what we saw during the second wave is that, we sort of learned about, the new variant very, very late. If we had that kind of intelligence even a few weeks earlier, maybe we would have been able to save many more lives.
So can I ask a quick follow-up? So in terms of the intelligence, like what would be sources of intelligence to get you that early detection?
So I think like a community network of local physicians that practice. So we learned, this is exactly how we learned about the Delta wave. So in Maharashtra, in Nanded, we saw a network of family physicians, who were practicing their day-to-day. They were seeing patients every day, and they saw that entire families were getting infected with the virus. And that was a departure from what they saw during the first wave. And, they probably didn't report it for a few weeks, but if there was formal communication, they would have probably reported it much sooner than they actually, made a group and then reported it.
Well, would an education then also be part of like what, I guess now the lesson learned for that aspect related to the communication is if you see in a pandemic like this or a virus that's, spreading, if you see changes and what would be kinds of changes to be a lookout for that says, okay, you saw this, it's more going through the family much more rapidly or whatever, like you just mentioned, and to say, okay, that's where you need to alert. I'm just wondering if there's also education that, should be make people aware and clinicians.
Absolutely. So I know that several states built the COVID health task force sort of settings. And if there was some sort of two-way street going on where there would be, these doctors would have been better kept into the loop, I guess, by the task force and vice versa about any changes in pattern or behavior, with a new virus, that would have been immensely helpful. So the speed of reporting should go up. So that kind of agility is something that we need to achieve in like the local intelligence systems.
Great, thank you.
Mm-hmm.
Thanks, Priyam. Thanks, Rita. I think that's a brilliant point on the intelligence systems that, we often talk about it, but I think it's really important now to sort of put it on the forefront of major healthcare related discussions and discourses that we have.
Yeah, and I want to add to this. So we had, mass protests going on for political in nature, but for a few months before, we had the Delta wave hit us. So we, like in any protest, there was a huge public, large scale protest. So lots of people gathering in a small sort of, space. Now I know that the doctors and the medical community and the health experts sort of instinctively knew that we had the original variant and we had the new variant from the UK that had come in. And if people with both of these variants sort of intermingle this much, there is a huge possibility that it may mutate into something new. So instinctively, I know that the medical community was, talking amongst themselves, but if only there was a more formal sort of structure that was in place to identify what was going on, we would have been able to detect it much sooner, I think.
Awesome. Agree. And I guess we do have, that's I guess a good segue into the next question that I had for you regarding, there were also quite a few safety nets that were put in place by the government, including very incredible economic safety nets to sort of really protect us from the huge economic debacle that we could have seen. So what are your thoughts on it, while you were doing your research and speaking to, say, a few government stakeholders? Number one, what is the planning behind it, and how did they actually make such a huge rollout in terms of the quantum of it?
So we obviously, didn't have the resources like many countries in the, in the West and do to per capita to kind of give out financial packages. So we had to really spend money very prudently, which is where the free food grain program sort of really contributed, So we already had stockpiles, we're agro country, so we had, we knew we had to feed the people, but we also knew that if we give out cash in hand, people, this is just the way Indians are cut out. People are not going to use that cash and stimulate the economy. They're going to save that cash. Yeah, that's just how we're cut out, So it's still not going to achieve the purpose of stimulating the economy that a cash in hand voucher should do. So the food grain program obviously took care of the basic needs, the hunger needs, but then it also left us money to put into sectors where we would see a multifold sort of impact. So if you see, we spend about 300% more money in infrastructure. Now that provided, jobs to these to migrants that went back to their home states and home villages. It also allowed for the entire industry, the infrastructure related industry, steel, cement, etc., to sort of keep up and going and keep the economy going. So we and we really didn't give out like one big bang financial package that would make headlines everywhere. We gave out smaller packages after like intervals, after we saw the feedback on the ground, because we knew that we didn't have that kind of money to splurge. We had to really only spend it where we would see returns, and of course take care of our very, very vulnerable. So here's the other thing, that we used the direct benefit transfer, the DBT system, to transfer money immediately to our most vulnerable sections of society. And that was great because, we avoided that entire corruption and passing of money through various hands, etc. And we were, immediately and directly able to credit the money into the accounts of the very vulnerable populations. So, like, of course, like a bunch of like a combination of things, that we did correctly when it comes to, managing, the economic policies that, are now sort of showing the reward.
Do you also think then in that case, the government's work in the recent years on the technology, the digital payment aspect of it, sort of really helped in assuaging a lot of those economic problems that we could have faced, the challenges that we could have faced?
Yeah, absolutely. I mean, the way that Indians have taken to technology, be it payments, be it bank accounts, be it adopting CoWIN even. We Indians have really taken to technology much more than we think, and that of course really helped in shaping the economic policies, but it helped us in the vaccination drive even. It helps us in communicating with the last mile even. So that's incredible,
Awesome. In your answer, Priyam, you did mention about the migrant exodus, the migrant related issues, and I'll hand it over to Brian for the next question that you may have on this, I suppose.
Thank you, Priyanka. Yeah, I wanted to follow up on the point that you were raising around both social protections as well as social protections specifically for some vulnerable and marginalized communities. So I work in UP, which together with Bihar had to manage a large influx of migrant workers returning from elsewhere after the initiation of the lockdown in March of 2020. And this was as many of us know, the subject of many public discussions and even some controversy to some extent. And so I was wondering if you could comment on how the government and local communities responded to the needs of migrant workers during this time in India.
So in late March 2020, thank you for the question, Brad. So in late March 2020, just before the lockdown was announced and the government sort of wanted to announce the lockdown, it was a very catch-22 sort of a situation for the government, because it's not that they forgot about the migrants. They obviously knew that we have this huge, large section of people that will be out of jobs and will want to return home. Unfortunately, we simply did not have the infrastructure and the tools in the home places, in the home states, to handle those kinds of caseloads. The whatever little public health infrastructure that we had in some of those states would have very, very quickly crumbled. And we would have really lost a lot more lives than we did. The food grain program was almost immediately announced. So wherever the migrants were, they didn't have to sleep. They wouldn't have to sleep hungry. But here, sometimes it's also important to remember that this is like a human psychology sort of thing, that when you think you're going to die, you want to die at home. You want to be home, you want to be in your comfortable environment. And I think that's something that sort of took over whatever planning that the government did. And we saw that exodus, because at that point, of course, nobody knew anything. People just thought that if you're going to get infected, the government's going to come and take you, probably in an isolation center. You may or may not come back from it. There were all kinds of rumors. And when that kind of fear, is there, you want to die in your home. You want to see your parents, your kids, your family. So I think that's really what drove the migrants back to their homes, and the government simply could not enable that enable the transfer at that point in time, because they didn't have that infrastructure.
So can I ask a follow-up?
Yeah, yes, please.
So I've been curious to know, have the migrants who returned back largely to states in the north, have they stayed now that things have opened up? If so, is this an opportunity for growth within these states? So are there opportunities? I know in UP, for example, there was a database of opportunities for migrant workers based on their skills that were being utilized in other states. Has this played out in helping to strengthen the economies and the local communities in these states, UP, Bihar, others in the north?
So I definitely think that a lot of them who went back have stayed back. And we see that by an increase in uptake of the rural employment guarantee scheme. So we saw sort of like an uptake there. Also, some of these states like UP, Bihar, Madhya Pradesh, they really, when the formal entry of the migrants began into those states, these states sort of did the skill mapping exercise on the borders. And with the mapped skills, the government helped place them, they placed them in infrastructure jobs. Since we were spending all that extra money in infrastructure, they helped create local businesses, even got them access to funds. We have so many examples of villages that have turned into ecosystems of, say, small scale industries like trouser production or, manufacturing of quilts or, denims. And I think this was because of the skill mapping exercise, which the government first did, and then helped them financially build that ecosystem. So definitely, we have a lot of these migrants who found those sources of employment, staying back and not returning to the urban centers.
That's great. Thank you, Priyam. And I think it's a great opportunity, if there's a silver lining in this, to strengthen those communities and those economies in these states. So thank you.
Thank you.
Thanks, Prem. I guess a lot of important challenges that we are discussing on this, and sure, I guess in challenges and discussions lies the way ahead for finding solutions to the problems. So great discussion. Kunchak, over to you if you would like to ask your next question.
So one thing that I noticed is, fear really drove a lot of things on the ground. Right? People wore masks, people were isolating because they were afraid. Now things are loosening up. People might let their caution down. So I wanted, communication is essential. How science is communicated from the government to the people, that's really critical. But then I wanted to know what worked in terms of science communication and what could have been done better. Could it be related to vaccines, precautionary measures to reduce exposures or lockdown policies? So how effectively that can happen. And then especially, new variants might come up or a new pandemic might come up, right? So how do we maintain that?
So thank you for this question. So I do think that at some point we have to we simply cannot have a population stay in fear for an extended period of time. That would cause fatigue, and that would cause rebellious behavior even. So it's a very thin balance that you want your people to listen to you when the time is crucial, and you want to sort of loosen your hold when you're more confident about community safety. So that's one. Number two, we have in our prime minister, incidentally, while this pandemic struck, a great communicator. He enjoys the trust from the people that not many world leaders enjoy. And we've seen that. We've seen that play out around the world, that after COVID, we've seen most countries either change governments or oust their existing governments, or actually democratically vote for the opposition. So we've not seen that in India. We see continued trust in the existing government. So that says a lot about how people perceive the prime minister and what he has to say. And I think he knows that. So right from the beginning, he didn't allow that sort of confusion to occur, and he sort of took charge of communicating directly with the people, and he gave out a lot of national addresses, teaching them even how to wear a mask, demonstrating how to wear a mask, getting a vaccine, urging people to take a vaccine, urging people to kickstart businesses even when people were too scared to come out of their homes after the lockdown. I remember that he had to go on national television and say, Jaan bhi, jahan bhi. That means that, okay, you can't just, try to protect yourself and stay at home. You have to get out and work. So we saw that in our leadership, and we saw the messaging from the prime minister to the health department to even the state governments sort of stay consistent most of the time. And I think that really helped.
And also, if I'm wondering if it could also, in addition to the leadership, it was exemplary, having a system-based education delivery, to the public. I think
Yeah.
that's important.
Yeah,
Through the
you're
health
right.
system.
Absolutely. So I remember that in the early days when there was a lot of confusion, a lot of fear, people didn't know what was going on. The Ministry of Health and Family Welfare, they used to hold these 3 p.m. Media updates every day. And then sort of that, gradually went down to say 3 times a week and then 2 times a week, and that really was a confidence building exercise because everybody was at home, everybody was watching the news. People didn't know what to believe, but when you had the government come out and say that this is what it is, this is what we're doing, and this is where you should be careful, I think that was that systemic sort of response.
Thanks, Priyam. Before I hand it over to Shri, I was curious, in terms of the local media participating in the communications. What were your observations, Priyam? So we do have the big shots like Republic TV and NDTV, just to name a few, Aaj Tak, etc. But then what was the experience like trickling down the information to the local media campaigners or champions?
Yeah. So of course, this is a double-edged sword. You need the media to transparently pass down the messages to the last mile. But then it's the media, and then they also take up stuff that brings them TRPs and that's, we've seen that sometimes they haven't really played their part responsibly. And we've seen that a lot, and not just in local media, we've seen that on national media as well. And I mean, so they do have to take accountability, especially in crisis situations like these, and especially, and to curb that, that's when the government began those 3 p.m. Conferences to kind of,
That's interesting.
Yeah, to kind of tell facts from fiction.
I do agree. It's a very, a very unbalanced sort of space to navigate. Very careful sort of stepping onto that particular space. Shri, over to you for your next question.
Sure. Yeah, I want to talk about maybe like sort of surprising and extraordinary cases and examples of responding to COVID. So one exceptional example is the Nundarbar model. So this is that tribal district in Maharashtra with about 1.6 million people, I believe. And what they did is they ensured optimum use of medical oxygen through systematic and effective planning that resulted in substantial reduction in these single-day COVID cases. So when you did your research, did you come across similar examples, and can you share some of the insights?
Yeah, so absolutely. So this is interesting because when the second wave struck, we simply didn't have that much oxygen, for the kind of caseloads that we were seeing. And we really needed to, audit the oxygen that we were using. And that's something that could not be controlled at the center. Local governments and state governments had to really control it. We saw that in Kerala, that they managed their oxygen, right from the beginning, really, really well. So did Maharashtra. And at one point in time, they were needing, so for example, with the same caseload in Kerala and Maharashtra and in New Delhi needed 5 times more oxygen than Maharashtra and Kerala were needing. So Kerala was using, so I keep forgetting the name, but there's a model where they used 1 refill of oxygen for 5 patients simultaneously. And they had a really good system that they had put in place. And then we had other states who didn't put systems in place, and we really paid the price for that.
Interesting. Thank you.
Awesome. When I was reading about this Nundarbar model, a few news articles, news pieces on that was really interesting. But also, I think we need to give credit to the local IS officer, the bureaucrat there, who because he's also from the medical background. So probably that really helped in navigating that particular space.
Right.
I definitely had a couple of follow-up questions, Priyam. So we do, during this particular experience in the last 2 years, we have seen different stakeholders, government and private, coming together. So be it for the vaccine manufacturing, the dissemination, just one of the few examples. And like we were just talking about the scientific communications, or even the non-scientific communications rather. In your experience, well, we do understand the significance of it, but then what can be done better in terms of, sort of really solidifying this public-private partnership and infusing it as a very strong element within the healthcare system's value chain of it?
So I think that in a country like India, which is so diverse, geographically, population, government, any party, I think, that they should realize that government cannot be in the business of doing business. They simply cannot, just because of how diverse we are. And to be able to really achieve scale, we have to take help from private players, and not just take help, but sort of help them with resources, financially, sort of help them financially, regulatory approvals, fast track those, and create that circle of trust with the private players, and promote entrepreneurship. That has to happen. Like, the government cannot, centralize, especially in a country like India.
Yeah, I would totally agree with that. Especially, we saw that as the pandemic progressed, initially during the first wave, engagement or involvement of the private players were not that much.
Mm-hmm.
And then during the second wave, there was a much more collaborative, inclusive. I think there was lessons that learned during the first wave that went on and actually informed the decisions that were taken during the second wave. Be it in terms of patients, admission of the COVID patients, or even allowing them to test for COVID, which was not allowed initially during the first wave for many of the private centers. So I think those sets of things, they really play a crucial. Government systems can be easily overwhelmed.
Yes.
Which was during the second wave, during the Delta wave. A lot of people died.
Yes.
I think there are these things that we should continue to learn from our past experience, and then go on to inform the future decisions. Laying out scenarios. If this happens, we're going to do that, and sort of. I think that would be important in terms of preventing deaths and saving lives moving forward.
Yeah, absolutely. And I mean, who knows what the next pandemic is going to be? So I mean, it's impossible sort of to create a handbook. The only handbook that you can pass on is advice that systems need to stay agile. Communication between government, people, and industry needs to stay tight. Intelligence between friendly countries has to stay close. So, I mean, these are the only things that you can pass on, because it's so unpredictable. The nature of pandemics.
One thing that we learned from this pandemic is we cannot predict things.
Yeah.
We are bad at it.
Yeah. True.
Totally agree. Awesome. Shri, over to you.
Sure, yeah. Being the engineer, I can't leave without asking about technology. So I actually have a new master's student from India. He was from IIT Delhi. And in his application, what struck me was he worked on optimizing food and supply delivery to the people in the villages using data science, and some AI. Don't know all the details of where he got all that information. But what I'm interested in is, did you come across really interesting stories of innovation in terms of technology on, say, vaccine outreach, people residing in these rural areas and so forth? And could you share some of those stories?
So two things. One very physical story that I want to say, that early in the first wave, when we really didn't have any tools, like we didn't have PPE kits, ventilators, masks, any of that stockpiled, we had to involve, of course, the public sector to help. And at that point, we were not making any ventilators in India, for example. We had only about 16,000 ventilators in circulation, and all of those were imported. And there was not one private firm in India that made an entire ventilator from and including components in India. So even they were relying on importing components. Unfortunately, because of the global supply chain issues, we couldn't import components. So we had to find a way to make new components very quickly in the country. So I think that DRDO and a couple of private companies got together and they found a really innovative solution. They got HP on board and they made some of those components with 3D printing technology. Mm-hmm. And I think that's a great example of innovation. With looking into the future, I feel that yes, today we credit the ASHA workers to go to the last mile for vaccine delivery, but maybe the future is to use, and I think the government is promoting this, to use drones for these kinds of last mile deliveries. So I think that's something that we should work on, to achieve scale.
Fantastic. Yeah. Interesting. Thank you.
Mm-hmm.
Actually, that news on drone that when I read, I think it was piloted already.
Yeah.
That was fantastic.
Yeah.
Really commendable.
Pilot drone in Chamba in Himachal Pradesh that I knew of, that was actually, I think, for tuberculosis in the past that I was aware of. I think drones can be an excellent model, but TB serves as an excellent model for a lot of diseases. There's this food of transport, there is transport of medicines that can be done through the drones. So there is a whole area in technology, and then also a lot to learn from disciplines, right? COVID derived heavily from the tuberculosis systems that we have put in place, even using manpower. But sometimes what happened is the other system was at the loss, like, TB suffered globally. We are seeing rise in cases, right? That other system got. So I think moving forward, it would be important to leverage each other. How we can draw strengths together, right? Not just have a vertical system, maybe a horizontal system. If we are screening for tuberculosis, maybe within that same screening model, maybe some other diseases can be included. I think those kind of innovations in systems screening in terms of preventions, those could be important, should be explored. That's what I would think. And in each, one size doesn't fit all. So each nation, each region, each community may have its own different model.
Mm-hmm. Yeah, absolutely agree. We have a system like CoWIN that can be repurposed to accumulate patient data, medical history, health policy, like health insurance coverage. So absolutely, some of these things that we put in place must and should be repurposed.
Awesome. Love this conversation on repurposing technologies. Great. We still have a couple of minutes, precisely 2 minutes left before the end of the hour. So over to you, Brian, to ask any final questions.
Thanks, Priyanka. So the story of COVID-19 everywhere in the world, I think has been an important chapter in the story is COVID-19 vaccines, and India being one of the largest supplier of vaccines to the world, one of the largest vaccine manufacturers. I think features prominently in that important chapter of COVID-19. And so I was wondering if you could tell us a little bit about India's COVID-19 vaccine development story, how states and other departments were engaged, what hurdles were faced, and how those hurdles were overcome.
Sure. So from a very early stage in the pandemic, I think the government knew that we would have to make our own vaccines because the existing manufacturers simply would not prioritize billions of us over other parts of the world. B, it was very expensive, to pay $20 for vaccines that we would or would not be able to transport safely. So from very early, the government knew that we would have to work with the private companies and develop vaccines which were affordable and easy to transport. And that's when they sort of risk funded several of these companies. And, even before the trials began, and sort of supported them with regulatory approvals, any kind of raw material sourcing with diplomatic channels, all of that, so that we get our vaccines in the quantities we want on time. And taking this on a more sort of global level, like today we can manufacture 5 billion doses, and they're all affordable. And I think a lot of the developing countries can and should use the Indian vaccines, which may be easier to handle than some of these more difficult to handle vaccines in the market. So yes, that's where we are. We did go through some periods where we thought that we had those vaccine shortages, but that was short-lived because we significantly scaled up production in the second half of 2021.
Awesome. And with this, we're actually a little bit over the end of the hour, but thank you so much, Priyam. I think it was a very healthy discourse that we had on various, and I'm so glad that within this 1 hour, we are able to sort of include a wide range of subjects. And thank you really, Brian, Shri, and Kunjal Khan. Thank you enough for sort of coming on board and conducting this wonderful session. So thank you all and see you soon.
Thank you. I really appreciate it. Thank you.
Thank you,
Bye,
Priyam.
take care.
Take care.
Thank you, Priyam, for being with us.
Thank you.
Bye, everyone.